Good evening, everyone. Welcome, and thank you so much for joining us for this virtual UMiamiHealth Talk. The topic tonight is congestive heart failure, novel approaches to management and recovery. I'm health journalist Ileana Bravo, and I will be your program moderator for this evening. We have many of you joining us, so we're happy that you will be participating with us. Tonight's UMiamiHealth Talk is presented by UHealth Virtual Clinics. UHealth expert providers are ready to care for you. They can do it in our facilities or virtually, wherever you are. We invite you, of course, to learn more about the measures we have in place to keep you safe, as well as your appointment scheduling options by visiting umiamihealth.org. Well, tonight we're going to hear from two University of Miami Health System cardiology experts, Dr. Luanda Grazette and Dr. Joshua Hare, speaking on the innovative congestive heart failure therapies and treatments that are available and being developed by the University of Miami Health System. Now, during each panelist presentations, we'd like to tell you that we are going to poll you, the audience, to gauge your knowledge, your interest, and there will be questions relevant to this discussion. Your answers will be anonymous, and they're an important part of the conversation, so please be sure to take part. I'll walk you through that. Also, we're going to have a Q&A session to answer as many questions that you have. Some have been submitted in advance, and others you have plenty of time to do so by looking at the anonymous Q&A feature at the bottom of your Zoom screen. Make sure you locate it now, the two little bubble boxes there on the lower right-hand corner. You can answer your questions as you think of them, and we are going to prepare them for our panelists to address at the end. So with that, I am very pleased to introduce our first presenter, Dr. Luanda Grazette. She is director of the UHealth Heart Failure Innovation and Treatment Program and an associate professor of medicine at the University of Miami School of Medicine. She earned her medical degree from Harvard Medical School and is fellowship trained in cardiovascular disease and cardiopulmonary transplant. Dr. Griset is double board certified in cardiovascular disease and advanced heart failure and transplant cardiology. Dr. Griset, take it away. It's all yours.
Good evening, everyone. Thank you for joining us. These are my disclosures. Heart failure is a syndrome in which the heart can no longer meet the metabolic needs of the body. And it's helpful to think about the fact that the heart is a pump that is responsible for generating the projectile force to send nutrients and blood throughout the body. It has two phases, diastole when it relaxes and fills, and systole when it contracts and injects. Heart failure can be caused by any structural problem or functional problem that impairs either of these portions of the contractile cycle. And cardiomyopathy, which is an acquired or inherited abnormality of cardiac muscle, is a form of one of those structural impairments. So patients can have cardiomyopathy without having heart failure, and many patients have heart failure for reasons other than cardiomyopathy. Impairment of either systole or diastole can cause reduced cardiac output, and reduced cardiac output is actually the root cause of heart failure. Now, from a symptom standpoint, it's also the cause of many of the recognized symptoms of heart failure, because the failure to be able to eject blood properly leads to blood essentially backing up into the lungs, backing up in the abdomen, backing up into the feet, so that you have edema and bloating and problems breathing. When we're recumbent at night when we sleep, because of gravity, that fluid that may distribute throughout the body during the day tends to pool and re-equilibrate in the thorax and in the abdomen, which is why many people find it more comfortable to sleep with many pillows or upright when they have the syndrome of heart failure. Now, the reduced cardiac output is associated with other symptoms such as the low energy and sometimes even confusion. Now, the low cardiac output also causes a host of other issues, and I will promise there will not be a test on this slide, but I raise it just to communicate the issue that heart failure is not just a problem of the heart. That low cardiac output causes problems for the kidneys, the nervous system, the adrenals, because all of those systems are interconnected. through reflexes that help to keep our bodies within a normal functioning parameter. And having the syndrome of heart failure disrupts that delicate balance. Most of the medications that your physicians prescribe for heart failure are designed to reestablish normal function of the neural hormonal system, or neural hormonal modulation. That is the term that's typically used to describe medications for heart failure. So we have the angiotensin receptor blockers. Those are the ARB drugs, so many people may be on valsartan or candesartan. The ACE inhibitors, which are the original heart failure drugs, lisinopril, captopril, enalapril. The beta blockers, Coreg and metoprolol, and the mineralocorticoid antagonists. All of these drugs have been shown over many years now, decades now, to improve survival, improve function, and improve quality of life in scores of patients with heart failure. And we actually see the results of that, because up until quite recently, if you went online and you Googled heart failure, you would come across a statistic that stated that patients diagnosed with heart failure had a 50% chance of dying in 5 years. And what those statistics didn't mention is that that statistic was from 1971, a long time ago. People were wearing bell bottoms. The truth of the matter is that since that time, every few years we see improvements in survival with heart failure because of disease modifying therapies and also disease modifying devices such as CRT devices and defibrillators, which have really modified the curve of heart failure. And if we look at our most current data for survival in heart failure, we no longer talk about median survival for heart failure because we don't really know what it is. The most recent study that looks at a large enough population for the longest period, this study in 30,000 Medicare patients, 70% of them are still alive at about 8 years. And so we have to wait for this population to age a bit more before we'll know what the median survival after a diagnosis of heart failure is at the current time. We have learned a lot, and a lot of things have changed between our early era of heart failure, when patients with stage B or asymptomatic left ventricular dysfunction proceeded fairly quickly to stage C, symptomatic ventricular dysfunction. And many patients died from arrhythmias, sudden cardiac death. That's been mitigated by our defibrillator devices. And then many patients died in stage D. And if you look at the present era at the bottom, you can see that the arrows have gotten longer. So patients, after they're diagnosed with heart failure, are living longer than they did in the earlier era. More patients are surviving with heart failure. In fact, we have more patients with heart failure in the US now than we ever have before, about 6.5 million. And the majority of patients actually don't progress to this last stage of intractable symptoms as they did in earlier days. The other thing that we have learned most recently is, if you look, there are a couple of arrows headed in the other direction. What does that mean? Can you go backwards in time? We used to think not, but in fact, it is possible to have recovery, or I think it's actually better described as remission in heart failure. And so with appropriate application of our disease modifying therapies and devices, it's no longer uncommon for patients to have recovery of function and at times to remit to having absolutely normal function while on medication. So why don't we do that all the time? Well, one barrier, one obstacle is that we don't really know why it happens when it happens. And part of the important work that we hope to undertake at our Heart Failure Innovation and Treatment Program is gaining an understanding of why it happens for certain patients and not for others, so that we can direct therapies toward recovery and remission of heart failure. Another reason why we don't see recovery, another obstacle to recovery and remission in heart failure is despite the fact that we have really, really effective drugs, the most effective drugs that we've had ever, with new drugs coming online every year, only about 60% of patients are on all of the drugs that they should be on. And that number used to be much lower than that. And there was a lot of effort from cardiologists and hospitals developing disease management programs to ensure that patients had access to appropriate medications and were maintained on appropriate medications. But even with that, it is the case that in clinical trials populations, only 60% of patients are on all of the drugs that we think they should be on. And part of the reason for that is just physiology. Most of the drugs that I've discussed have an effect on blood pressure, and many of them have an effect on renal function. And so physicians and patients are often walking this tightrope of trading off hypotension and renal function for being on good therapies. So what else is there when we get to the point where therapeutic options are limited from a pharmaceutical standpoint? We have devices. So I'm not going to go through this slide. If you want to take a little time and read it, it's just there to communicate essentially that LVADs are not a new invention. They were designed at about the same time that the heart and lung machines were designed to allow complex surgeries for patients with cardiac disease, but really came online in the 80s. And in our current era, we are in the era of continuous flow devices, which are far more dependable than anything that we've ever had before, and kind of ushered in a new era where continuous flow LVADs are considered a treatment for heart failure in the same way that we think about our medications and the same way that we think about transplant. The devices are fairly simple in that there's a centrifugal pump in the current design, so kind of like a tilt-a-wheel that the blood spins around and is propelled throughout the body. And what's really exciting over the last 3 to 4 years is that as the technology has improved year over year and model over model, the survival with LVADs is, at least at the first 2 to 3 years, is very similar to what we see for cardiac transplant. And the technology continues to improve. So I pulled this slide for 2 reasons. One, to give you a real physical representation of how far we've come in a fairly short period of time. On your left, you have a patient of mine from about 20 years ago, smiling teenager, pushing his state-of-the-art VAD around the hospital. And it really was state-of-the-art because the controller there in the yellow circle used to be much larger than that. This was the improvement. It was the size of a mini fridge. And we were so happy to have this version that he could actually ambulate down the hall with. He was considered something of a miracle because the device failure with these type of VADs was so high that most patients wouldn't live more than a year and a half on device, not because it failed to support them with their heart failure, but because the devices failed or they clotted or patients had infections. You contrast that to the patient on the right, who has now what is considered an older model LVAD, and you can see his system controller, this tiny little kind of fanny pack device that he's wearing on his hip. It's hard to even see his batteries, which are there in a little vest under his arm, and each one lasting for about 10 hours. This gentleman actually received his valve when he was 78, about 10 years ago, and he's still going strong. So we have learned as an advanced heart failure community that advanced age is not a contraindication. And in fact, older patients may have some outcomes that are better than younger patients. The most important things for all patients, but especially for younger patients, is to consider this intervention earlier, before the onset of weight loss and debility, because in order to have a good recovery from this type of surgery, it's important not to be too frail at the beginning. So we've seen, basically amazing innovation over the last 3 decades, and we expect that will go on. There are devices that are in development now that will not require external battery packs, and we expect to see those within the next 10 years. So what else is there? So I mentioned earlier on that in addition to the hormonal changes, there were issues with the nervous system and how the nervous system adapts, sometimes appropriately, sometimes inappropriately, to heart failure. So why not do something directly with the nervous system? Well, it turns out that you can. So we can use devices that are very similar to pacemakers to stimulate parts of the nervous system in order to engage the type of outcome that we would like. And the outcome of this, what's called neuromodulation, really just depends on where we apply the therapy. This is not an entirely new idea. So the first successful clinical trial was in the mid-60s by Dr. Nina Braunwald. And Dr. Braunwald, in addition to being one of the first cardiothoracic surgeons, missed by 2 weeks being the first cardiothoracic surgeon to implant a mechanical valve. But she actually designed and sewed her valve herself. So I think she still should get a lot of credit for that. The device was actually really effective in reducing the pain of angina in patients who had intractable coronary ischemia, but the surgery CABG became available, and so that was a better treatment for angina, and the trial was never completed. So it's possible to target the vagus nerve or but even better for us at heart failure is the Barrow reflex. And the Barrow reflex is a neurologic reflex in the neck that integrates kind of our fight or flight response with our relax and chill response. Because for patients with heart failure, their body is always telling them you're in fight or flight mode. And a lot of the medications are designed to trick the body into going back into relax and chill mode. The baroreceptors control that. And if you stimulate the baroreceptors, you can get more of that relax and chill mode from the parasympathetic axis, which is the proper name for it scientifically. And engaging that parasympathetic axis basically triggers a lot of the things that we want to happen in patients with heart failure in terms of diuresis and reverse remodeling to have that kind of recovery and remission that we're looking for in our patients. So the Barostim Neo is a device that is currently approved to do just that. You can see on the right-hand side, someone's hand gripping the tiny little stem sensor, and you can see right of that, the little device is a small pacemaker type device. And then the controller, which is, or the programmer, which would be in the doctor's office. It's actually a very simple technology. It has been implanted in clinical trial settings in over 1,000 patients. And in the most recent trial, which resulted in the FDA's approval of device, patients were able to walk farther. So on 60-minute walk test, which is a standard test in heart failure, there was a 60-meter difference, which is huge. Patients felt better. Patients had better scores on the Minnesota Living with Heart Failure battery of tests, which is a battery of questions which essentially asks how well you're living and how much heart failure impairs your life. So on the basis of that, this device was approved in 2019, although the trial itself is still ongoing, because we're also looking to see whether or not there will be a mortality benefit in addition to that. And the last intervention that I'm going to talk about is the cardiac contractility modulation, or CCM device, which is another type of pacemaker type device. It's called the Optimizer, and it's called the Optimizer Smart System for Heart Failure. And what it does is it takes advantage of the normal cardiac cycle by placing essentially stimulation that prolongs that contraction of the heart. And by prolonging that contraction of the heart, there is an immediate increase in the left ventricular contractile force. And in terms of what patients feel or felt during the clinical trial, patients again had improvements in quality of life, improvement in exercise tolerance. And when it was looked at scientifically, there was also evidence of reverse remodeling, which is what we call the changes that we see that precede a heart going into remission or recovery. And it was actually approved in 2016 in Europe and was just approved more recently here in the US. In fact, both of these trials were approved in Europe and have been in use for many years. But prior to, I would say, the last 5 years, the focus in the US from our FDA has always been on survival. So it was very difficult to get any types of interventions approved that didn't prolong survival. But patients have spoken to their physicians and have spoken to the FDA and have communicated over and over quite effectively now that survival isn't the only thing, and that quality of life is as important and sometimes more important than quantity of life. And because of that, the FDA and heart failure investigators consider quality of life and other important patient-reported outcomes as important and significant as prolongation of life. So this is now a goal, a legitimate goal in treatment of heart failure. And we hope to add promotion of recovery and remission as well, as soon as we can better understand how it happens. So this is an evolving story, and I invite you to stay tuned. And thank you very much for your attention.
Thank you, Dr. Grazette. And I remind our audience members that Dr. Grazette will stay with us, of course, for the entirety of the hour so that you can direct questions specifically to her on some of the things that she shared with us. But now it's my pleasure to turn it over and introduce Dr. Joshua Hare, the Louis Lemberg Professor of Medicine at the University of Miami Miller School of Medicine, Senior Associate Dean for Experimental and Cellular Therapies, as well as Director of the Miller School's Interdisciplinary Stem Cell Institute. Dr. Hare earned his medical degree from Johns Hopkins University School of Medicine and is double board certified in cardiovascular disease and advanced heart failure and transplant cardiology. Dr. Hare, it's my pleasure to welcome you tonight.
Thank you so much, and good evening, everybody. Well, I want to thank this audience for joining us this evening, and it's my pleasure to continue the discussion that Dr. Grazette has already begun about the reversal and treatment of heart failure. And as my titles indicate, I spent a lot of time doing research to learn about new strategies and new ways to treat heart failure and cardiomyopathy, because we perceive that there is still unmet need. With all of the great drugs and devices that we still have a long way to go. Heart failure is still the #1 cause of hospitalization in the United States today. That might have been overtaken in this past year by COVID-19, but for the most part, this is still a very, very serious condition. Here are my disclosures. What I want to do for the next few minutes is really simplify things And this is an oversimplification as indicated from the question. We're not going to talk about all of the things on the question. We're going to try to simplify it down to the two main causes and the three main problems that we have with heart failure right now. So what has become apparent to us in the last only decade or so is that you can generally divide causes of heart failure into two: reduced ejection fraction or preserved ejection fraction. Preserved ejection fraction has become so common that it now has its own name, which is HFpEF, and that stands for heart failure with preserved ejection fraction. Prior to our recognition of HFpEF, we thought mainly that reduced ejection fraction was a requirement to have heart failure, but we now know that's incorrect. But when we come to heart failure with reduced ejection fraction, there are two main causes that we think about most of the time. Cause number one is a patient who's had a heart attack from a blocked vessel in which heart muscle can die. And then the second main cause is not from a heart attack, but it's a disease of heart muscle cells itself. So what is ejection fraction? I think Dr. Grazette touched on this, but ejection fraction is the percentage of blood the heart muscle ejects with each beat. It's normally about 50 to 70. And when we talk about reduced ejection fraction, we're talking about less than 40. So our group here has been very, very interested over the last 20 years at trying to use cell therapy to fix some of these problems. Now, we started out over many, many years and many, many millions of dollars of experiments trying to see if we could fix heart attacks. I told you that a heart attack happens when heart muscle cells die, and that's an irreversible process. So the question we began to ask was, can we fix this with stem cells? And this is an example that I want to show you. This was published 7 years ago, and I show this example because it's very easy to see. This is a patient who's had a heart attack, and this is what we call a high-resolution MRI scan. And you can see that the heart muscle dead area is colored in red, and the normal is in gray. So you can see in this patient, this had this very extensive scar shown in red, and when we injected this scar with stem cells from bone marrow, we indeed showed that we could dramatically reduce it. And I think you can just clearly see visually, this is the same patient before and after 18 months, and there's this dramatic improvement. So this has spurred the field on over the last 7 years, and there have been many, many more studies that have been done and published since that time. Now, I want to continue on a theme that Dr. Grazette began, which is to talk about what are the things that patients really care about if they've got congestive heart failure. And that is, as she mentioned, it's not just lifespan, but it's also quality of life and events that can reduce quality of life. In the field of cardiology, we use an expression called MACE. And MACE stands for multiple adverse cardiac events. And when you have an adverse cardiac event, that means you're not doing too well. Very typical adverse cardiac events are needing to be admitted to the hospital or having to be seen in your doctor's office or the emergency room. So the thing that's very exciting right now is that since that publication 7 years ago, the most recent studies that have been done, which are the most advanced studies, have shown that consistently that there's this reduction in MACE events and an improvement in quality of life. And there'll be two big studies that'll be announced this year, the DREAM-HF study and the CONCERT-HF study. They both show improvements in MACE and improved quality of life. So we're very excited about this because we think that we really have, after decades of research, shown that this therapy has merit and probably should be approved soon and will start to be used in general terms by cardiologists throughout the United States. Now, what about a cardiomyopathy or heart failure that's not due to that heart attack? Well, we call that idiopathic dilated cardiomyopathy. And here's an example of a heart that's been afflicted by idiopathic dilated cardiomyopathy. I think what you could see, and the reason I'm showing you this picture, is that there's no scar tissue. The heart muscle all looks nice and pink like muscle should. And so the question is, why does this patient have heart failure? And why has this heart gotten so big that it looks like a basketball, which is much bigger than it should be? So in our work over the last several years, we decided to do the same kind of tests on patients with idiopathic cardiomyopathy as we had done on the patients who had had the heart attacks. We took these patients and we injected them in an experimental setting with a stem cell injection right into the heart muscle. And lo and behold, we were shocked, but favorably shocked, to see that a large number of the patients we were treating in this fashion had a recovery. Dr. Grazette also mentioned heart failure with recovered ejection fraction. And so there is actually the potential here for reversal. So here we take a patient whose ejection fraction is 19%. We treat them with stem cells, and 1 year later, it's now 43%. It's above 40%. Anything that's above 40%, we call heart failure with recovered ejection fraction. And that's a very good thing. People with heart failure with recovered ejection fractions are doing much better clinically. And when we looked at all of our patients in the study, we could see that about half of them have the heart failure with recovered ejection fraction. They're going from below 40 to above 40. That's the definition of heart failure with recovered ejection fraction. And in this case, we refer to them as super responders. And there you could see the numbers highlighted there of the ones who are going above 40% after the cell therapy. Now, when we looked at these patients further, we also showed that they have this improvement in MACE. And I'll take you through this slide in a little bit of more detail. We wanted to know who were the super responders from the non-responders. And what we did was we did genetic testing on these patients, because we know that about 40% of patients with that condition, the idiopathic cardiomyopathy, have it because they inherited an adverse gene. An abnormal gene is responsible for their cardiomyopathy. So we did genetic testing on all of the patients, and we looked at the outcome of those who had a genetic abnormality from those who did not have a genetic abnormality. And lo and behold, the patients without the genetic abnormality, the ones in this green line, had the best outcome. 100% of them survived 400 days, and none of them had a MACE event, whereas all of the MACE events occurred in the patients with genetic abnormalities, shown in the red and yellow lines here. So this was a very, very exciting observation. And I'm very pleased to announce that because this was so important, we've decided to start a new, bigger study of 136 patients that will look and prove that this is in fact correct. And we're hoping that that study is going to begin next month. So if you know anybody who has an idiopathic cardiomyopathy who's potentially interested in being a participant, please feel free to contact us. So here again, it shows that the genotype modifies the response of cell therapy. The patients in the green who don't have a gene, these are the ones who have the greatest increase in ejection fraction, whereas those who have the worst genetic abnormality have even a reduction in their ejection fraction. They get worse. So we're planning to do this much bigger study now to prove that that is absolutely correct. So that's really what we've done with cell therapy. I've summarized about 20 years of work in just a few slides, and we now have a new poll question.
That's right, and it is, can you have a normal ejection fraction and still have heart failure?
That a situation with normal ejection fraction can still lead to heart failure. And as Dr. Grazette really beautifully showed us in her diagrams, the heart doesn't need to have a low ejection fraction. It can become stiff or develop this condition that we now call HFpEF. It's so common, it has its own name. And what we know about HFpEF is that It is a condition of aging. The older you get, the more likely you are to have HFpEF. And women are more likely to suffer from HFpEF than are men. We don't understand those particular issues, but there are lots and lots of studies that are being done. And at our center here at the University of Miami, this is one of the top areas of interest in our research program. Now, the biggest problem with HFpEF is not so much that it's the normal ejection fraction, it's that all of the medicines that we have proven to work for patients with a reduced ejection fraction, for some reason, don't have the same beneficial effects in HFpEF. So we're struggling because we have an increasing number of people with this condition and a relatively shortage of medications that are effective. So this is a very problematic condition. As I said, it's an increasing percentage of patients and resistance to usual medications. But one of the things I just want to share with you in my last few slides is that because we're a research program and academic medical center, we're not just about treating patients with the best possible care now, which we are, but we're also thinking about the future. We're thinking about how we can make things better and do the kinds of research that lead to these new advances. So one of the things we've been have had the great benefit and privilege of doing is working with a very prominent scientist here at the University of Miami who won the Nobel Prize for his discoveries about how hormones affect the rest of the body. And he and I have just published a study to look at how hormones that are called growth hormone releasing hormone agonists, it's a mouthful, so for short we call them GHRHAs, affect people with HFpEF. We believe that these hormones could be beneficial in HFpEF in a way that is specific for HFpEF because of the basic science studies we have done in the laboratory. So just one of my last slides is to show you we just published less than a month ago, January 26, 2021, in the journal, the Proceeding National Academy of Sciences, our work with this growth hormone releasing hormone agonist in an experimental situation of HFpEF, heart failure with preserved ejection fraction. But the results from this study are so compelling that we plan to take this into an early stage clinical trial very soon, maybe as soon as this year, if the Food and Drug Administration will allow us to. And I just want to give a shout out to my very valuable and honorable colleague, Andrew Shalley, who is the inventor of these drugs and the winner of the Nobel Prize. So let me end there. I always end with the same slide, which is the slide that thanks all of the people and colleagues in my laboratory and throughout the University of Miami, without whom this work would not be possible. And always a special thanks to the National Institutes of Health that is so generously funding our research here and has allowed us to do all of the work I've shown you, along with some very, very generous philanthropists, the Sofer family, the Star Foundation, and the Marcus Foundation. So thank you very much again, and we appreciate your taking the time, and we're happy to spend the rest of the time answering questions.
So let's launch right into the question and answer session and get in as many as we can. You are sending them through the Q&A chat box and we are monitoring them. All right, Dr. Hare, here's a question. Do you use the patient's own stem cells for treatment? And as an add-on, how are the stem cells introduced to the heart?
Okay, terrific questions. So our group has done a lot of work trying to determine whether the cells are better coming from the patient themselves or from a donor. And we have probably done the most work on that particular question in the world. And what we found, I didn't go into that in a lot of detail in my talk, but what we found is that the cells from a donor probably are better. We think that that's the case because the patient who's sick with congestive heart failure, that syndrome that's affecting their bodies also making their bone marrow cells impaired. So in our most recent studies, we prefer to use cells from a donor That also adds a tremendous feature of convenience because the cells can be made ready and are basically what we call an off-the-shelf product that can be used right away when needed. The way that they're introduced into the heart is with a catheterization procedure. So much like a patient would have an angioplasty or a valve replacement through a catheter, we can introduce those cells directly into the ventricle with a special catheter that's got a tiny needle at its tip. And we've also done a lot of work, a lot of experiments and clinical trials with that to show that that can be safely done and effective. And the beautiful thing about that is it doesn't require surgery. It's not an open chest procedure. And we envision a time in the future when we're doing this, where it'll basically be an outpatient procedure. Right now, we're still keeping people in the hospital for one night, but in the future, we're quite sure that it'll be outpatient.
Here's one for Dr. Grazette that I think is important to address. Is it possible for a person to fully recover from congestive heart failure and lead a normal life with prescribed medications, proper diet, and exercise? In other words, can it be overcome, or is it always considered chronic?
So absolutely, and I've seen that, and I'm sure Dr. Hare has seen that in patients that we care for, and it's absolutely possible. It's hard to predict who it's going to happen for. Anecdotally, almost all the patients that I've seen it happen exercise. Exercise is, I think, one of those interventions that's very underappreciated. What we have found, though, is even after patients have recovery or remission, however you'd like to describe it, it's important that they stay on some of their heart failure medications because there is a very high likelihood of developing heart failure again for those patients who decide to come off of meds.
And for instance, Dr. Grazette, if a patient who's, let's say, had a heart attack, have a low ejection fraction, is it better to implant one of these devices, a defibrillator, earlier on before it becomes worse and into heart failure?
That is an interesting question. So with the defibrillators themselves, I will say that that's been very well studied in terms of which patients will have the most benefit in terms of being rescued from sudden cardiac death. Now, with some of the other devices that I spoke about in terms of the CCM, the optimizer, the study actually did show that patients who were a little bit healthier than what we, in terms of their ejection fraction, have higher ejection fractions than what we would usually talk about for receiving a defibrillator, actually have more benefit. And we will be involved soon in a trial in patients with heart failure preserved ejection fraction, which will carry that question a little bit further. So I do think there's a role for that, and it's being defined.
Very good. This questioner asks, how does diabetes affect treatment of heart failure?
Diabetes is really challenging because it's a very well-known risk factor for heart failure. And part of what happens in diabetes is that, especially for those patients who tend to have diabetes for a long time, it can actually infiltrate the heart, sort of byproducts of sugar metabolism infiltrate the heart and contribute to heart failure preserved ejection fraction, which is, as Dr. Hare mentioned, one of the conditions that we have a more difficult time managing in terms of treatment options. Now, in the last 3 years, there have been a couple of medications that were originally designed or envisioned for treatment of diabetes that we've seen have really great efficacy for patients with heart failure. It's not clear that they have more of a benefit for patients with diabetes, but these drugs that specifically modify or have an effect on essentially sugar and salt metabolism, and probably some other things that we'll be pleasantly surprised by in the future. But diabetes is a challenging problem, and it's helpful to make sure that your diabetes is under as well controlled as possible.
Dr. Hare, I'm going to give you two stem cell questions
Okay.
together because there's so many. Can the heart failure be severe and still respond positively to stem cell treatment? And let me give you a second part. Can stem cell therapy help patients with idiopathic atypical hypertrophic cardiomyopathy? So take one at a time.
Yeah, so the first one, in terms of how severe the heart failure is, we have found that, and again, our findings are experimental. I want to be clear that the FDA has not approved the cell therapy yet. I got a lot of questions offline on that. So the field is at a phase 3, and we're waiting to see what the FDA is going to do with the data they have this year, whether they'll ask for more data or they'll give an approval. But it's gone through phase 3. We do know that the benefits are seen at all degrees of severity. And there have been experiments and studies that have been done across the gamut. And so severity is not a particular showstopper in any way, from the least severe to the most severe. If you're a candidate, you're a candidate. Now, for hypertrophic cardiomyopathy, this is a very complicated type of cardiomyopathy where the heart muscle is very stiff and thick. And so we don't want to do anything in that situation to make more heart muscle grow. In fact, one of the ways to treat that hypertrophic cardiomyopathy is to reduce the heart muscle either by a surgical procedure or by what's called an alcohol septal ablation, which destroys some of the tissue. Now, the exciting news about hypertrophic cardiomyopathy is that there's a new drug that's coming down the pipeline that's specifically for hypertrophic cardiomyopathy. And the results that have been done with this drug to date are very encouraging. And so somebody with hypertrophic cardiomyopathy should see their cardiologist and ask about this new drug for specifically for hypertrophic cardiomyopathy. It's the first time that there's been a drug that was made specifically to address hypertrophic cardiomyopathy. So those of us who see these patients are very excited about having this drug come down the pike.
So regarding stem cell therapy, the bottom line is it's still in clinical trials. It is not readily available at this point. There's no Medicare coverage. It's just not there. It's
experimental, but it is gone. The experimental, for any new treatment, it has to go through 3 phases, 1, 2, 3. And what we're really excited about is that a phase 3 trial has been completed for stem cells for heart failure. But it's one and only. There's only one. And so we're waiting to see what's going to happen. So until the FDA gives an approval based on that phase 3, it remains what we call an investigational product, one that can only be given in the context of a clinical trial, and therefore one that is not subject to be reimbursed by Medicare.
Imagine not. Here's one that's kind of simple in its approach with people wanting to look at symptoms. Are swollen feet early signs of possible congestive heart issues? What's the difference between pulmonary edema and congestive heart failure?
Swelling of ankles isn't necessarily an early sign, it's a sign. And so somebody who has swollen ankles and they don't know why should see their doctor for an evaluation. Basically, there was another question on the chat pertaining to this, like how can you diagnose this? The one general guidance I want to give to everybody on the call is if you think you have any signs or symptoms of congestive heart failure, the answer of what you should do about it is really simple and is the same for everybody. Go see a doctor. Come and see us. That's what we're here for. We're here to do that evaluation and see you and do a history and physical and run the testing we think that is necessary, and then tell you what it is and what the treatment options are. So certainly swollen ankles, with something we call edema of the legs, is a sign, and people can have it early, medium, late. Pulmonary edema is when you get extra fluid in your lungs and makes you short of breath. That's another sign. And when people get pulmonary edema, that means their health is more in jeopardy, and they need to be seen even more sooner than later if you've got pulmonary edema. But that's what we're here for. That's what we do day in and day out, is see patients like that and do the proper evaluations to help patients understand what their situation is and to be on the correct treatments.
And thank you for that point, because that's important, which is why so many people have tuned in tonight. Dr. Grazette, a final question for you, and I think we'll have to wrap it up at this point. We got a lot in, but again, as Dr. Hare said, they're here for you, so patients can reach out. But the final question for Dr. Grazette is the mechanism of action of the releasing factor on congestive heart failure with preserved ejection fraction known or understood?
Yeah, I believe that sounds like they're asking about the mechanism of growth hormone releasing hormone. And that's a really astute question. I hope that's the correct question. What Dr. Shalley discovered is that this hormone, which was typically found only in the brain, actually has its receptors distributed throughout the entire body. And there is a receptor on the heart muscle cell for the growth hormone releasing hormone. And we've been studying the actions of this hormone on the heart muscle cell for 10, 15 years already, we and other laboratories. And we understand that when that hormone binds to that receptor on the heart muscle cell, it has a whole bunch of things happen. And we don't know which one specific to HFpEF, because there are at least 5 different chemical reactions that occur, but we're in the midst of studying that. So we know for sure that there's a receptor, and that you bind to that receptor, something happens inside of the cell. And what we've shown recently is that those molecules, which we call signaling molecules, result in a beneficial effect on the function of the HFpEF heart, which means we're ready for clinical trials.
I'll let Dr. Grazette get the last word in tonight. And I think that the tone of the presentation really was that there is hope, that congestive heart failure is not the death sentence that I think people used to think of many decades ago. So give us a take-home message, Dr. Grazette, for all of the people who tune in tonight and are listening for hope.
Well, I think that's a really great way to describe it. When I was a fellow years and years ago, we were taught that you got all of the cardiomyocytes, all the heart cells that you were ever going to have, you had them at birth. And if you had a heart attack and you lost some cells, or you had diabetes and you lost some cells, then you just have this progressive decline until finally you died. And, really thanks, starting with the work of people like Dr. Hare, who looked at stem cells and also looked at what was actually going on in the heart muscle. We found out that, whoa, wait a minute, the game's not necessarily over yet. And we've been very surprised with each new innovation that things are much better than they can be, much better than we ever thought before. And I don't think we're anywhere near the end of it. And I think we all look forward to seeing what comes next.
Thank you both so very much, and for ending on such an upbeat and positive note, especially after the year we've all been through. I think the people who tuned in tonight and would possibly want to come see you and get other opinions wanted to end with that. So with that, we have to say goodnight, and thank you so much for all of you to tune in, and for our 2 expert providers who were brilliant tonight. We are here to say that at the University of Miami Health System, we're here for you. We care for you. Visit UMiamiHealth.org to learn more, to make a virtual appointment if you'd like, or an in-person appointment with our experts. They're taking a lot of safety precautions to make sure that you're safe. And please complete the survey at the end to give us some feedback and maybe other topics. But thanks again, Dr. Grazette, Dr. Hare. We wish you a wonderful evening, and all of you have a great night, and please stay safe out there.